Thank you very much. It is truly a pleasure to be here this morning, and I'm honored to open this session on musculoskeletal imaging for this morning. And what I'd like to do is talk about some fundamental concepts in the analysis of osseous lesions. I recently was involved in a project evaluating radiographic assessment of osseous lesions and assigning a value for their biological activity, something that's been done many times, but not recently. And what I'd like to do is share some of my insights that I've learned on that project, in the sense that we had to review the literature, and it really was a very interesting thing. So for lack of a better term, I'd like to subtitle this A Brief History of Margin in the Assessment of Osseous Lesions. And specifically, at the completion of this session, what I'd like you to be able to do is recognize the fundamental concepts used in the analysis of margin in the assessment of bone tumors, identify how this has changed and why it has changed over the years since it was initially described by Ludwig, and how these changes are so important in the application of the new imaging modalities that we use today, specifically MRI and PET. Now, when we look at a solitary lesion of bone, as radiologists, we typically talk about margin and periosteal reaction and matrix. Matrix is a key to the underlying histology. When we analyze that pattern of bone mineralization for cartilaginous or osseous structures, we can even use it on MR when we look for myxoid matrix or fibrous matrix within a lesion. Margin and periosteal reaction really assess the biological activity of a process, the relationship between the lesion and the host, and it's so critical. And of those, of course, margin is key, because there is no better indicator of the biological activity than the interface between the lesion and the host, as demonstrated by that margin. And so what I'd like to look at today is the concept of margin. Again, how it's changed over time and its importance to the current imaging applications. Now, to go back through history and we look at how this whole thing started, we can go back to the early days in the late 1800s, and here a picture of Julius Wolff, who is an orthopedic surgeon and anatomist and the first professor of orthopedic surgery at the University of Berlin in 1890, and he did his research for doctoral research in bone remodeling, analyzing fracture healing of bone. And he came up in 1892 with a book called The Law of Bone Remodeling, and he analyzed the trabecular, the architecture of bone, and he said the trabecular orientation adapts its architecture to externally applied loads. And the trabecular morphology, and we talk about this, trabecular morphology matches stress trajectories, and we know that. And eventually this morphed into what we call Wolff's Law, that every change in the form and function of a bone is followed by specific definite change in its internal architecture and equally definite secondary changes in its external configuration. Well, that's all well and good, but what has that got to do with anything? Well, look at a bone. The bone supports the skeleton. It provides the structural stability. And really, a long bone, for example, is just a thick tube, a column with a strong cortical margin that thins, and the bone in that margin is replaced by a latticework of trabecular bone. When we put a hole in that bone, for a tumor, for example, that changes the distribution of the biomechanical forces that go across that lesion, and that alters the distribution of these forces and stresses. And given the time, the bone will remodel to reinforce itself to adjust to that. And given the time, it will form a sclerotic margin. And that's the basic concept that we use. And we know from early work that things that grow slowly in bone are indolent and benign and tend to form that sclerotic margin. And that forming of that is really a time-dependent phenomenon. Things that grow rapidly are considered aggressive and more typically malignant. Now, of course, osteomyelitis infection can go through that entire spectrum, but those are fundamentals. Now, we also know that the rules for bone cannot be used for soft tissue, because things in soft tissue that are highly malignant may grow very slowly. But for bone, these work, and they work well. Now, Ludwig used this, and we all think of Ludwig's classification. And he really was a brilliant individual. He talked about analyzing bone lesions, and he took all this information, the location, the age, the size of the lesion, its shape, its matrix mineralization, and most importantly, he assessed the margin. And he looked at the patterns of that margin and the pattern of bone destruction. And what he did is he went to the AFIP and he studied fibrosarcoma of bone. And he looked at the patterns of bone destruction, and he basically came up with 3 types. A geographic pattern of bone destruction, and we talk about that if you could take your finger and course it around the margins of a lesion like you would the margins of a map. We call that geographic. He said it could be moth-eaten, giving the appearance of many scattered and confluent holes of moderate size, giving the impression of arising from multiple foci. And finally, it could be permeative, tiny multiple holes in cortical bone which fade imperceptibly from an area that looks like it's maximally involved to one where the cortex looks quite normal or intact. And he had these basic 3 patterns that he looked at, and when he analyzed these fibrous sarcomas, he noticed that when he correlated the pattern of bone destruction with the 5-year prognosis of the patient, he saw that those that had a permeative pattern of bone destruction, there were few survivors at 5 years. Those with a geographic pattern of bone destruction had many survivors at 5 years, and those with a moth-eaten appearance had an intermediate number of survivors between those 2 extremes. And hence he had these 3 basic patterns of bone destruction. And then, using his words, through a detailed observation of radiographic patterns of tumor behavior at various levels of malignancy, he subsequently developed 5 patterns of bone destruction, those same 5 patterns that we learned about when we were residents. He subsequently divided that geographic pattern into 3 separate patterns, designating them 1A, 1B, and 1C. And of course, the moth-eaten and permeative patterns that we've talked about. And these were the patterns of bone destruction that were described by Ludwig back in 1964, over 50 years ago, that we still use today. And he said then, most of us, perhaps without recognizing a logical basis for such a decision, assign a certain growth rate or degree of malignancy to a tumor based on its radiographic image, specifically addressing that pattern of osseous bone destruction as recognized by evaluation of its margin. So this is what we're left with, and this from a classic article by Madewell in 1981 of the geographic moth-eaten and permeative types of destruction as they presented it at the old AFIP. Now, it's important to emphasize that these are patterns of osteolytic bone destruction. So if you look at a lesion such as this and you use those terms, geographic, moth-eaten, and permeative, they really don't fit because they were devised for osteolytic bone destruction. And if I have a lesion that's blastic, or the matrix is so blastic that I can't evaluate the osteolytic part of it, I really can't use that imaging system. So this really is not appropriate, although that looks relatively well defined, and you might argue that that's somewhat infiltrative. Certainly, that's not appropriate to classify by Ludwig's classification system because it's not an osteolytic lesion. Now, I will draw your attention to this article by Madewell in 1981. And I always learned that these were the patterns of osseous destruction. But more recently, I went back and read some of Ludwig's original work. And what Madewell described and what has been taught at the AFIP, the old AFIP and now the AIRP, for probably at least 35 years, really does not accurately reflect what Ludwig had on his initial assessment of osseous lesions. And if we go back and look particularly of the geographic lesions, they're different. While we had this short definition provided by Madewell, Ludwig actually used 14 descriptive variables to describe each of these 5 patterns of osteolysis. And while Madewell's was much simpler, they really are different in many respects. And this is from Ludwig's early papers, and if you look, really it's quite a complex way that he talks about the analysis of lesions. And nobody has done it for more than 35 years that way, because everyone today uses that Ludwig, not the original Ludwig classification, but the classification that was modified by Madewell. And really, the classification system we use today is not really the Ludwig system, but really a Ludwig-Madewell classification system, and something that really has only been recently described in those terms. And it's actually a much simpler way to do it. And I know John Madewell well. He was, when I was at Walter Reed as a resident, he was at the AFIP, the chairman and registrar, and when we would get ready for our bone tumor conferences, we'd go over there and review the cases with him. And he's a remarkable person. As a first-year resident, he would say to me, well, what do you think of this case? And no matter how stupid your answer was, he would find something clever in it that he'd say, well, that's correct. And then he would tell you why everything else you said was wrong. And I know John very well, and I think he's really why I went into bone radiology. And I called him and I said, well, John, why did you change this? And he said, well, Ludwig's definitions were just so difficult to apply that nobody would use them. So we got with Len Johnson, who was the pathologist that worked with Ludwig, and Don Sweet, who was a pathologist at the AFIP at the time, and they modified these as best they could to make them easy to apply. And this is the system that we use today. And I think Dr. Madewell doesn't get the credit that he deserves, because it really is a very nice, easy to apply classification system that he devised based on Ludwig's original material. In addition, he added 2 additional types of bone destruction, again, that aren't really given the credit that they deserve: the invisible margin, which today has become very important, and the changing in combination margin. And we'll talk about each of these. So let's very quickly go through the literature, or go through some examples of these so we can see what we're talking about. First, the one we're all familiar with, the geographic lytic lesion with a well-defined sclerotic margin, always exemplified by the non-ossifying fibroma or fibrosanthoma here, where we can see this nice sclerotic margin, again indicating an indolent biological behavior, seen nicely on the radiograph and the gross specimen shown here. If we look at that lesion, we can see how well defined it is and how the host trabeculae blend imperceptibly with it. If you'll notice also that there's some expansile remodeling. Now remember, bone is rigid. It's not a balloon. It cannot expand, but it can have new bone formation and have an expanded, remodeled contour. We as radiologists don't really call that periosteal reaction, but in fact it is. And if we talk to our pathology colleagues, they would call that a shell-like periosteal reaction, but certainly some expansile remodeling. And here the nice macroscopic section showing that sclerotic margin blending imperceptibly with the adjacent trabeculae, with some xanthomatous areas at the more proximal portion of the lesion, and histiocytic changes more distally. Another example of a non-ossifying fibroma with that beautiful sclerotic margin seen nicely on MR and radiographs. Now we know that benign lesion sclerosis is not just for a non-ossifying fibro, but there's a whole host of lesions, again, reflecting a relatively indolent, non-aggressive biological behavior. And if you look through the literature, between about 93 and 94% of the 2 largest studies that have looked at that have been benign when we see that kind of a margin. Well, what could be malignant? Well, we know certainly clear cell chondrosarcoma can have a sclerotic margin, and sometimes very indolent metastases, as we might see with thyroid carcinoma. But most all, not always, but probably 93 to 94% in the literature would certainly be benign. Here another example of a benign lesion, a beautiful example of this sclerotic margin which fades to the periphery, typical of a Brody's abscess, and here a cyst with a sclerotic margin in the intertrochanteric area. A more aggressive pattern of osteolysis is that where we see a geographic lesion, take my finger, course around it as I would the margins of a map, with no sclerosis in the margin. What we call the cookie cutter type lesion. in this classic image of a giant cell tumor, which nicely demonstrate that well-defined, not sclerotic margin as we see the tumor extending from the metaphysis towards the end of the bone. Nicely defined on the macroscopic section with some mild expansile remodeling or periosteal shell new bone formation. And we can understand why it has this well-defined, not sclerotic margin if we look at that margin and we can see the advancing area of the tumor causing the destruction of bone. Now, tumor doesn't destroy bone, but it stimulates the host osteoclast to remove bone. And in this case, the tumor is growing at about the same rate as the host osteoclasts are removing the host bone to give us that well-defined margin. And here at higher power, we can see, in fact, those host osteoclasts going to town having their breakfast on the host trabeculae. Again, a balance between the tumor growth and the resorption of bone, giving us this well-defined, not sclerotic margin. Again, a higher biological activity seen with a host of lesions, most typically benign, but certainly we know that things like myeloma and some metastases may have this again. This has been reported to be benign in about 56 to 94%, that 56 from Lodwig's original study, and from the largest new study to evaluate that, with that 94, and we'll talk about why that changed in just a moment. And that was a mistake there. That should say benign rather than malignant on that previous study there, and I apologize for that. And here are some examples of this well-defined, not sclerotic margin with this unusual subchondral cystic lesion, and of course the multifocal lesions over here representing myeloma. A more aggressive pattern of osteolysis is when we see a geographic lesion with an ill-defined margin, as nicely shown in this case of fibrosarcoma of bone. And we always classify lesions by their most aggressive pattern of osteolysis, and you can say, well, maybe that's well-defined, not sclerotic, but certainly the majority of the lesion has this ill-defined border, and if we look at the macroscopic section, we can see exactly why. We can see that the tumor is growing fast enough that it's encasing the host trabeculae before the host osteoclasts can remove it, while in other areas they're partially removed, and other areas they're completely removed. Again, it's the combination of all of these that give us that geographic ill-defined margin in this fibrosarcoma. And again, as you would expect, the number of lesions that are malignant on this lesion on this type of margin is increasing, as shown by the following list. And again, about half of those lesions with a geographic ill-defined margin will be malignant, and about half will be benign. And here, a case of Langerhans cell histiocytosis with a nice ill-defined margin. And here, another patient with, I think, really got a pretty good ill-defined margin. This was an orthopedics surgeon's son who had some pain in his wrist. His father put him in a cast, and it didn't go away in 2 weeks, and brought him in and had this lesion there. And you can very nicely see that ill-defined pattern of osteolysis with a few sequestra as well, and a little single lamella of periosteal new bone formation on the CT in this patient with osteomyelitis of the metaphysis of the distal radius. Now, special attention is deserved for the changing margin, which was very nicely introduced by Madewell. And it represents a change in biological behavior. If I showed you this case and showed you that sclerotic margin, you'd say, yeah, that looks pretty indolent, benign. But when you look at that lateral cortex, that looks just downright ugly. And CT beautifully shows this with this area of sclerosis and, of course, this destructive lesion laterally in this benign lesion that has undergone malignant transformation. And this is an important concept because as radiologists, when we're asked to biopsy this, we have to biopsy that area of the greatest biological behavior. So it only tells you not that the behavior is changing, but it tells you where to biopsy. And this was a high-grade malignant fibrous histiocytoma arising in a previous benign fibroosseous lesion, likely an intraosseous lipoma with involutional change. And this was a really nice example of such a lesion seen at the AFIP, where you can see that sclerosis, the very destructive changes, and the corresponding macroscopic section, again showing that high-grade sarcoma arising probably in that ischemic bone that forms at the margin of the lesion. Now, when we go to the higher types of margins, such as the moth-eaten and permeative type, it becomes a little hard sometimes to separate them. And Lodwig even said that they often will occur in the same lesion together, although he really thought that they were separate processes. And again, one can argue whether that's really true, because it is hard to separate them radiographically, but we'll pretend we can. And we'll talk about the moth-eaten margin as scattered and confluent holes of moderate size, giving the impression of rising from multiple foci, which can be seen in cancellous or cortical bone. And again, it is hard to find an example that any self-respecting moth would claim as their own, but here an example of a patient with osteosarcoma with multiple holes within bone seen nicely on the specimen radiograph, again giving the accession or the impression of arising from different foci and a confluent area of destruction more distally in this osteosarcoma. And if we look at the macroscopic section, we can see this due to endosteal scalloping of different degrees, giving us this pattern of osteolysis. And again, typically these are malignant, and in Lodwig's original study, 100% with this pattern were in fact malignant, but he did not include any cases of osteomyelitis. And here, some additional examples of this moth-eaten pattern in two different patients, both with lymphoma, primary lymphoma, osseous lymphoma. The most aggressive pattern that was originally described was the permeative pattern. This type 3 pattern was described as having multiple tiny holes in cortical bone which fade imperceptibly from a zone of maximum involvement to a cortex which is quite intact. And here I think an example radiographically where we can see the osteolysis in the proximal head, and as we go more towards the shaft it really does look relatively normal. On the specimen radiograph we see the same pattern. Perhaps when we look at that distal area at a little higher magnification, we can see that it really isn't quite normal with these areas of cortical tunneling secondary to osteoclastic activity or bone loss centered on the Haversian system and the Volkmann canals, but still the same basic idea of maximally abnormal tending to go back to normal as we move along the bone. And certainly, again, lesions that are usually very biologically active, as you can imagine, most typically, but not invariably, malignant. And again, in Lodwig's original evaluation of his system, he didn't have any cases of osteomyelitis and very few cases of Langerhans cell histiocytosis, and he did have 100% of those patients with that pattern as malignant. And here just a patient with Ewing sarcoma, very nicely showing that permeative pattern of bone osteolysis. Now I'll just mention this, we talked about a changing margin, and Madewell also talked about a combination margin, just to emphasize that this is not uncommon at all. Here a patient with a giant cell tumor of bone, and if you look carefully, and I would suggest if you look carefully on any patient with that, you often will see areas of sclerosis as seen here, some that perhaps well-defined, not sclerosis, some that are ill-defined, very typically seen in giant cell where we have multiple patterns, and we always go by the pattern of most aggressive in classifying a lesion. And certainly when we have the changing margin, as we talked about before, it represents a focal area of increased biological activity, and we can see it on serial images, or as we saw before on a single image. And here a patient with a changing biological behavior, and this patient with a medullary lesion. That cortex anterior looked pretty good, came in 7 years later, looked a little scalloped and a little osteolytic, and this was a low-grade chondrosarcoma arising in a previous enchondroma. Again, a key to a change in the biological behavior. Madewell also deserves credit for describing the invisible margin, the fastest rate of growth with little or no radiographic change, in the concept that the tumor is growing so rapidly, it encases the host trabeculae before they are destroyed. And here we can see this high-grade chondrosarcoma of bone. We look at the specimen, it looks really pretty much a normal trabecular pattern, but yet histologically it's completely infiltrated by tumor. Do we see this today? Yes, we see it very frequently, and we see it often in cases with MR imaging where we have the radiograph on this patient with primary osseous lymphoma where it looks pretty normal, and you can see the tumor infiltrating around the host bone, which is still intact. So it's an important concept and one that we see not infrequently. Now, the problem with these invisible margins is there are good invisible margins and evil invisible margins. And we just looked at a very evil case of lymphoma, and let me show you this patient. This patient with an incidental enchondroma that was invisible on radiographs, probably due to its small size, and we'll talk more about that in our next session as to why this really is a simple enchondroma, but again, an invisible lesion. And I would ask you what you think of that distal femur if you think it's normal. I certainly thought it was normal in this patient who had this unusual lesion in his posterior fossa, which was his metastatic synovial sarcoma. And here we can see that metastasis, a smaller metastasis inferior to it, and that synovial sarcoma in his proximal posterior calf. And he had this lesion within the bone on PET, but nothing on the radiograph. And when we did the MR, you can see this lesion, which has that beautiful enhancement pattern of septal and peripheral. We made the diagnosis of an enchondroma. He was given a above knee amputation because of the already metastatic foci and the highly aggressive pattern histologically. But it's a beautiful example of an invisible lesion. And why is it invisible? It's invisible because although it's a space-occupying lesion, it's surrounded by fat, and there's no bone to remove. And remember, in order to appreciate a lucency on a radiograph, we have to remove between 30 and 50% of the cortical bone present that's there, or the total bone that's there. And if it's just infiltrating the medullary fat with no cancellous bone there, it is virtually invisible unless you can see a matrix or some other suggestion as to why it is within there. And so, again, an invisible lesion. And so our job as radiologists to separate the good from the evil when we see such a case. Now, very quickly in the last few minutes, I just want to talk about a little comparison between the Ludwig system and the modified Ludwig system and the Ludwig-Madewell system. Here, combining the grade 2 and 3 lesions together in my schematic, when we look at the way Ludwig did it, and this from one of his earliest papers, he did a test library. He just put lesions together and analyzed them, and he came up with these figures, and they pretty much make sense. Benign, most often the case when we have a well-defined sclerotic lesion, typically malignant, in his case 100% when we have that permeative or moth-eaten pattern, about 50-50 in the geographic ill-defined, and again with that what Madewell called the non-sclerotic geographic lesion, he had about 56% benign. When we look at how Madewell did it, and now I've added that Ludwig-Madewell system with the changing and invisible margin, when we look at the results of that in a recent study where they had the same test library, although they had an expanded one where they included osteomyelitis and more cases of Langerhans cell histiocytosis, the results are relatively similar when we look at those, and if we put them up together, they look pretty similar. The biggest change between the two, a little bit in the grade 2 and 3, again because Ludwig had no osteomyelitis and very limited Langerhans cell histiocytoma. But the bigger difference in that 1B, what we would call well-defined, not sclerotic. And if we look at the way Ludwig originally classified them, when they had a poorly defined or ragged margin, he would still call it a 1B if it met some other criteria. Whereas when Madewell changed it, he made that well-defined, not sclerotic. And so that really is the biggest change between those two. But overall, the systems work relatively well. So, in summary, let me say, margin is probably the single best accurate marker of biological behavior of a bone lesion. And while the descriptions of margin have changed over the years, their significance really has not. A changing margin, remember, indicates a change in biological behavior, and an invisible margin may reflect the most aggressive biological behavior, but caution is required, and then it must be interpreted in the context of the case to exclude those incidental lesions that we see quite frequently on CT and MR. And in summary, I would say that careful analysis will accurately predict when bone goes bad. Thank you very much.